So for those of you that I have not met yet, my name's Liz. I am a first-year fellow here in adult nephrology. And back in the day when I was a struggling intern, I constantly found myself at odds with the serum creatinine in management of my patients with AKI. And so after one too many delayed discharge plans and foiled diuretic plans, I became acutely aware of the limitations of serum creatinine in managing AKI. Now, as a nephrology fellow, the serum creatinine still dictates my life, but I am empowered to ask what else is out there. So today I chose to focus on outcome prediction in sepsis-associated AKI and the world beyond serum creatinine. So I'll start with a patient that we all will know. So she's a 65-year-old female with diabetes, hypertension, hyperlipidemia, and she's presenting with confusion and productive cough. She's febrile, hypotensive, and has a multifocal pneumonia on CT, and her creatinine shows that she has a new AKI. Inevitably, in the next 24 to 48 hours, nephrology will be consulted with the consult question of workup and management of AKI. And how will she do? Well, the honest answer is I don't know. So today I'm going to split my talk into three parts. The first, I'll define sepsis-associated AKI and take a moment to talk about the pathophysiology. The second part, I'll talk about functional markers of sepsis-associated AKI and how they can predict the need for renal replacement therapy specifically. And then finally, I'll end with hopes for the future around overcoming heterogeneity and subphenotyping within AKI. So to begin, the working definition of sepsis-associated AKI was most recently redefined in 2023 by the 28th Acute Disease Quality Initiative Work Group, and it requires meeting both sepsis-3 criteria and AKI criteria by KDIGO guidelines when the AKI occurs within 7 days of the diagnosis of sepsis. So to remind ourselves, the KDIGO definition of AKI includes both serum creatinine and urine output, though as we'll address later, serum creatinine is by far and away the predominant measure by which we define it in research and in clinical practice. And then we will all remember in 2016, the pivotal moment when Sepsis-3 came out and SIRS criteria was deemed unanimously unhelpful. And we defined sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection, with organ dysfunction defined as an acute change in SOFA criteria greater than or equal to 2 points. All right, so I would say it takes about 5 minutes on a nephrology consult service to realize that sepsis-associated AKI is a really large problem. 50% of patients in the ICU with AKI do have sepsis, and sepsis-associated AKI is associated with higher mortality, a longer ICU stay, and poor long-term prognosis overall. And why should we bother trying to predict the outcomes of AKI in these patients? Well, most importantly, it will help guide patients and their families. But in real time for our practice, it can also help us prevent nephrotoxic injury in the highest risk patients, enrich clinical trials with very sick patients, target treatment interventions to those who would be most likely to benefit. And finally, it can help triage resources, and perhaps our pagers and consults may go down. All right, so now let's take a moment to dive into pathophysiology of sepsis-associated AKI. So we're all familiar with some of the basics of sepsis physiology. And briefly, a bacterial or viral infection will cause release of PAMP and DAMPs, which will activate the innate immune response. And sepsis is characterized by a hyperactive, dysregulated response, which clinically manifests in circulatory collapse, lactic acidosis, and hypercatabolism. Now, there's 3 main mechanisms which are consistent across end organ dysfunction in sepsis, and that includes inflammation, microcirculatory dysfunction, and metabolic reprogramming. So for the kidney, the PAMPs and DAMPs that are secreted are freely filtered into the tubule and bind toll-like receptors, specifically TLR2 and 4 on the renal tubular epithelium. activating the NLRP3 inflammasome, increasing vascular permeability, and causing infiltration of monocytes throughout the interstitium. Now, microcirculatory dysfunction is particularly interesting for nephrologists because historically it was thought that perhaps a decrease in renal blood flow and hypotension was a predominant cause of sepsis-associated AKI. But newer data has shown that renal blood flow can actually be preserved. And what really occurs is that the microcirculatory flow across capillary beds, particularly peritubular capillary flow, is significantly decreased. There's also a phenomenon shown here in this figure of glomerular shunting, where some blood flow bypasses the glomerulus altogether. And then there's loss of the supportive cells of the capillary beds called pericytes. Finally, within the kidney, there's metabolic reprogramming, which altogether is trying to prioritize survival of cells at the expense of cell function. And this causes decreased tubular expression of ion transporters and solute transports, cellular arrest, and then mitochondrial injury and a transition to aerobic glycolysis. So following these changes, there's a period of multi-organ dysfunction, diffuse edema, and pronounced immunosuppression. And in the kidney, there's one of two pathways that the organ can follow. Either adaptive repair, where there's proliferation and dedifferentiation of tubular cells and repair and regeneration of endothelial cells, or maladaptive repair, in which there's tubular atrophy, expansion of interstitial fibroblasts, myofibroblasts, and overall fibrosis with decreased capillary density and blood flow, predisposing to non-recovery and eventually CKD. All right, so now that we've established some of the unifying features of sepsis-associated AKI, we're humbled by the reality that's shown well in this figure. And that's that sepsis-associated AKI is not a singular disease state, but a highly heterogeneous condition. And we all know that after kidney injury, there can be many pathways that patients follow, whether they have early reversal and complete recovery, relapsed AKI, partial recovery, require dialysis, have early death, late death. And clinically, we try to follow the clues that are available to us to figure out if a patient will recover. And so now I'm going to focus on some of these metrics that we have and talk about specifically their ability to predict the need for renal replacement therapy. So starting with urine output. So as we discussed before, urine output is a criteria in the definition of AKI, but we all know that we rarely are able to accurately quantify urine output. And so for the great majority of AKI, serum creatinine is used as the definition. And multiple studies have shown that this is probably to our detriment. One published in 2015 by John Kellum out of Pittsburgh was a retrospective review of electronic records of 32,000 ICU patients. And what he did is he classified severity of AKI according to serum creatinine, urine output, or both. And now this table is a little difficult to interpret at first, but I think it shows some striking results. So focusing on stage 3 chronic kidney or AKI as defined by a baseline creatinine or creatinine greater than 3 times of baseline or greater than 4, we can see how the requirement of RRT varies by urine output. So those who are non-oliguric and have normal urine output have only a 3.2% risk of developing need for RRT. And once you have oliguria, then this jumps to 17.8% and 14.2%. And in the most advanced group, those who have oliguria for greater than 24 hours or anuria for 12 hours, the risk is actually 55.3%. So altogether, it shows that the discriminatory power of combined urine output and serum creatinine is far superior than serum creatinine alone to predict outcomes in AKI, and that when we have elevated serum creatinine in isolation, it may not actually have risk of significantly poor outcomes. Okay, so what about albuminuria? So we all know that albuminuria often coexists with acute kidney injury, but can it predict worse outcomes? So in a retrospective study of 423 ICU patients admitted for sepsis without pre-existing CKD or albuminuria, all of whom had a UA within 24 hours of admission. They looked at the outcome of new AKI at 72 hours. And as you can see, folks with severe AKI had a higher rate of new albuminuria than those who did not, but albuminuria was not able to predict whether or not there was going to be a need for in-hospital dialysis. And then this graph below shows that the magnitude of albuminuria is not associated with outcomes either. All right, so what about if we spin the urine? So here was a case control study done out of Australia, comparing 43 patients with septic AKI to 40 with non-septic AKI. And this group created a urine microscopy score, which was defined based on the degree of renal tubular epithelial cells and granular casts. And what they found is that patients with septic AKI were more likely to have a higher urine microscopy score than those with non-septic AKI, and that altogether a higher urine microscopy score was associated with a higher need for dialysis. But they weren't able to identify a difference in dialysis initiation between septic and non-septic patients. All right, so next I'm going to want to talk about biomarkers, but before I get there, I just want to take a quick statistical detour to define some important terms. So a prognostic biomarker is a characteristic that categorizes patients by degree of risk for disease occurrence or progression. And most often we look at the sensitivity and specificity of a given biomarker by a receiver operator curve, which displays the proportion of subjects who can be correctly identified with having a disease at various cutoff points for a given biomarker. And the performance can be quantified into something called a C statistic, which is the area under the curve here. And that's the probability that a randomly sampled case has a larger biomarker value than a randomly sampled control. And so to put it into very practical terms, you can see that a C statistic of 0.5 would follow this line and be a very poor model with no predictive assistance, whereas a C statistic of 1.0 would basically be a right angle here and be a perfect model. Okay, so I would be remiss to talk about biomarkers without first mentioning cystatin C. And so many of us know the theoretical basis for superiority of cystatin C over creatinine. And this includes that it's neither secreted or reabsorbed. It's produced at a nearly constant rate by all nucleated cells. And then interestingly, it's completely catabolized in the proximal tubule. And this becomes of particular interest for AKI research because in patients who have healthy tubules, the urine cystatin C should be near 0, whereas those who have proximal tubular dysfunction would have an elevated urine cystatin C. So in 2004, there were companion studies out of a single center in Germany that started to argue for a role of cystatin C in AKI. The first was in 85 ICU patients, case control, and it showed that serum cystatin C was able to predict outcomes earlier than serum creatinine with very high discriminatory power. And then the companion study looked at 73 hospitalized patients with non-oliguric ATN. And this looked at urine cystatin C and showed that it was able to predict the need for dialysis in AKI, again with very strong discriminatory power. Since these studies, I think other data has tempered this finding a little bit, but cystatin C, both urine and serum, is often incorporated into AKI models. Now, in sepsis specifically, so we can look at an interesting study that was done out of China, published in 2018. And this was 102 patients with AKI who were already on RT in the ICU, and biomarkers were measured at the time of discontinuation. The outcome they looked at was survival and renal recovery at 60 days. And they found that serum cystatin C was able to predict outcomes equally as well as urine output, and it was a stronger predictor of renal recovery than serum creatinine alone. So this becomes interesting when we think about the patients we're treating who have AKI, particularly in the ICU. So we know that they are going to be susceptible to large hemodynamic shifts, muscle wasting, and exposure to nephrotoxic agents that could cause serum creatinine variations that aren't necessarily indicative of organ injury. And here's a 2017 paper that looks at the relationship between discharge cystatin C from patients in the ICU and discharge creatinine and mortality at 1 year. And you can see that for cystatin C, there's an expected linear relationship predicting increased mortality with higher cystatin C. But for creatinine, this relationship is much more dampened. And so it sort of begs the question, are we looking at the wrong gold standard? Now, in addition to cystatin C, the last 10 to 15 years have led to a discovery of a library of biomarkers of injury and repair. And many of these can be measured in both the serum and the blood. So I've compiled sort of a non-exhaustive list here that's not for the purposes of reading, but just to show you that there's many different types that can be categorized based on tubular injury, inflammation, or fibrosis and repair biomarkers. So there's many studies that have leveraged these biomarkers, but one of the most cited in sepsis is a sub-study of the process trial. And this uses TIMP metallopeptidase inhibitor 2 and insulin growth factor binding peptide 7. These are secreted from proximal and distal tubular cells, respectively, and they're released in response to inflammation to promote cell cycle arrest in kidney injury. So the process trial looked at 688 patients who were diagnosed with sepsis, and they measured these biomarkers before and after a 6-hour period of resuscitation. And what they found was that for a composite outcome of severe AKI, dialysis, or death within 7 days, a higher amount of biomarkers after, but not before resuscitation, was associated with higher risk of the composite outcome and higher risk of death or RRT at 1 year. So while the case for kidney biomarkers holds a lot of promise, significant clinical advances in the field have been limited by really important pitfalls that I think are worth mentioning. So first, as with all AKI research, there's an issue of generalizability and that we study very heterogeneous populations with variable comorbidities. Second, and probably most importantly, there's an issue around normalization. So for urine biomarkers, they're appealing because they have specificity to kidney disease. However, we know that they would vary with eGFR and volume status. And so to account for this, many researchers normalize this to urine creatinine, but we know that in the setting of AKI, urine creatinine clearance is going to be dynamic and vary immensely. With serum biomarkers, they're often not stable, and they can be affected by interference with other serum proteins, especially with widespread inflammation. Additionally, there's an issue with standardization, and that standardization has not really occurred across studies, and there's variable cutoff levels that are based on the best fit in the population of interest in a given study. And finally, there's overlapping pathophysiology between AKI and CKD. And so for folks with underlying CKD, it's difficult to establish significance of changes. So all that data being summarized may make AKI research seem a little bit bleak, but being the first grand rounds of the new year, I should be optimistic. And so I'd like to talk about the future of overcoming the heterogeneity problem with subphenotyping. So guidelines and many publications now are moving towards subphenotyping. So what's the idea of subphenotyping? Well, the basic tenets involve big data from large heterogeneous populations. So taking a population, you can aggregate many types of different data, including demographics, omics, research biomarkers, as well as clinically observed biomarkers. And using statistical methods such as latent class analysis and k-means clustering, patients are distributed into classes. And this is based on maximizing similarity and across a minimal amount of groups. So does this work? Well, a lot of research says it does. including this study published last year by investigators at the KRI and collaborators in the Assess-AKI trial. So here on this left panel, we can see that patients in this cohort were separated into classes based on differential expression of the various biomarkers and demographic data seen here. And then when stratifying by these subgroups and looking for major adverse events, adverse kidney events, we can see that a previously indiscernible population separates well into 3 populations with differential risk of adverse outcomes. So now let's take a look at what this looks like with recent data around sepsis-associated AKI. And we'll start with a proteomic discovery analysis. So this was completed in 2022 in the Netherlands, and it took folks diagnosed with sepsis in the ED and collected blood within 30 minutes of enrollment. They matched patients with sepsis and AKI at 24 hours to patients with sepsis and no AKI at 24 hours. And then they investigated using a multiplex assay using 92 predetermined proteins in a commercially available organ damage panel and looked for differential expression. And the authors were able to identify 53 proteins associated with AKI among patients with sepsis, as opposed to patients without AKI. And pathway analysis revealed a role of many vascular endothelial dysfunction pathways, including specifically angiopoietin receptor Tie2 mediated signaling. So why is this interesting? Well, approaches that allow us to have unbiased identification of these pathways can have really important biologic implications. And this specific Ang2 pathway has become particularly interesting to me this year because of work I've been able to do with Dr. Pavan Bharaju and Lila Zelenik on AKI subphenotypes that are differentiated by this pathway. So taking us to molecular biology, so in normal physiology, constitutive release of Ang1 by parasites in vascular muscle cells binds its receptor Tie2 on endothelium and promotes anti-inflammation, anti-apoptosis, and anti-permeability. But in states of inflammation, Ang2 is released from Weibel-Palade bodies within the endothelium and inhibits this process, causing activation of pro-inflammatory pathways as a result of NF-kappa B and cytoskeletal destabilization. All that put simply is to say that if you have high Ang1 and low Ang2, you have a relatively healthy endothelium. And if you have low Ang1 and high Ang2, you have a leaky endothelium. So does that matter in sepsis-associated AKI? Well, a growing body of literature would say that Ang2 is very important in sepsis-associated AKI. And here's a sub-analysis done in 2 cohorts published by Dr. Bharaju in 2019. And this defined 2 subphenotypes of AKI, which were distinguished primarily by SP1 having a low Ang2 to Ang1 ratio and SP2 having a high Ang2 to Ang1 ratio. So SP2 being the leaky phenotype and SP1 being the healthier endothelial phenotype. And with regard to outcomes, we can see that patients with the SP2 phenotype were more likely to have 7-day renal non-recovery and higher 28-day mortality. And they also had distinct responses to vasopressor choice. So now we continue to investigate whether these subphenotypes can be replicated in other cohorts, and the work we're doing is currently on a sub-study of the Clovers analysis, looking to see if there's differential response to restrictive or liberal fluid resuscitation in early sepsis. So we'll have to stay tuned for that data. Now, before closing, I do have to bring us back to a humbling reality, which is that there's a very impressive amount of models in existence for predicting outcomes in AKI. And I think probably the metaphorical state of the union is most well summarized by this 2023 meta-analysis of 150 different risk prediction models for acute kidney injury. So they say that the discrimination of published AKI prediction models is good. However, the wide variation in the clinical settings, populations, and predictive variables likely drives the highly heterogeneous findings that limit clinical utility. All right, so circling back to our patient, we had a 65-year-old with an AKI, and will she need dialysis? Well, what can be useful in helping to predict this? Whether or not she's urinating, almost definitely. Albuminuria and microscopy may point to better or worse outcomes. Cystatin C probably has a role, and if we had the ability to measure biomarkers regularly, then maybe that could also be helpful. And then in the future, I hope that what I'd be able to do is categorize her into a subphenotype and tailor treatment and care that way, knowing about her risk. But collectively, looking at all this data, I think for now, I'll probably continue to just watch her serum creatinine. So I just want to thank Pavan Baraju, Mila Zelnick, and Dr. Hall for helping guide me with this presentation, and all the folks at the Kidney Research Institute who have contributed to a lot of this data that I presented today. Thanks.
Thank you, Liz. Really nice work, and clearly more to come. Questions for Liz? Something that I wonder about, maybe just another source of heterogeneity to add to the list is that the indication, the indications for RRT are also heterogeneous, right? So the way in which the kidney is failing is varied, and maybe different biomarkers, different ways that we're assessing kidney function may be more or less predictive of, renal replacement therapy needed for volume versus clearance versus something else, which of course will relate to different types of kidney injury in the hospital, and often those are mixed. So
yeah. That's a really good point, and I'm not sure that a lot of trials currently have the granularity that talk about why dialysis was indicated. Of course, I guess, thinking about sepsis-associated AKI and whether or not it's truly a diffuse volume problem, and then even etiology of infection, whether or not it's to dry out the lungs or to improve clearance if somebody has pyelonephritis. I agree, another source of variability.
Nisha?
Thanks, Kate. Liz, fabulous presentation. I had a question about the urine cystatin C. I think those data are really interesting as well. And, you mentioned one study in your presentation. Do you know the stability of measuring cystatin C in the urine?
It's a really good question. I don't. In terms of sort of how long afterwards there would be degradation of the protein itself.
Yeah. It's just not. And I think I'm not sure how well established the assay is as well. I think biologically, what are we capturing, and then are we measuring it correctly, are sort of my two questions, because I think those data were really interesting.
Yeah, I'm not sure. I'd have to look into it, but it may have changed over time. I know that early study was an incredibly strong discriminatory power, but it was in 2004, and I imagine 20 years later, assays have evolved.
Yeah, interesting. Great job.
Liz, I'm curious, since we just had a patient on our service whose creatinine went up to 15 and he did not require dialysis. The other things that we watched carefully were the degree of acidosis and whether he had hyperkalemia. And I'm wondering if that's part of the equation in some way. That's certainly not for those who need it for volume overload, but we certainly look at those to decide who might need dialysis.
Right, yeah, and in theory, they should all be captured with, depending on which criteria you're using, AKI on rifle or KDIGO criteria. Stage 3 does include need for RRT, so you could have a lower creatinine, and or regardless of the creatinine, could be indicated based on clearance needs. However, I think in the studies that I've seen, there tends to be a very few patients who are captured by the need for early RRT with the absence of the creatinine or urine output findings.
One last
Going
question.
off of that, this was a wonderful, excellent, genius talk. I was curious to hear your thoughts on basically, the pursuit of biomarkers versus really trying to understand patient factors that really help us to, predict the trajectory of AKI, meaning, are the patient factors more important than the biomarkers?
Yeah, I think that's a great question. I think I've been very humbled by how limited biomarkers in isolation are. But I think, particularly because of all the pitfalls that I outlined, but I think that in combination with really important clinical factors, controlling for comorbidities, and trying to assess similarities based on other sorts of disease markers, I think are really important. Many of the subphenotypes, and Dr. Bhattacharya probably knows this much better, but many of the subphenotypes don't seem to vary by demographics, but certainly in terms of clinical severity of illness, I think you're able to kind of categorize patients better.
One last quick question from Ian.
Sure, really great, Liz. One of the problems we have in AKI, of course, is lack of therapies. Any thoughts after going through all these biomarkers, how they might ultimately help us develop or apply new therapies?
I think the hope is for early therapy and trying to figure out, I think a lot of what Dr. Bhattacharya has worked on is how aggressive we should be with fluid resuscitation, targeting early pressors, which pressor we should target. And I think those would sort of be the immediate interventions that could be stratified by subphenotype.
Thanks again, Liz. Excellent work.